this next session for the next hour or so. So hello everyone, and just before we start with our lovely presentations, just a little bit of housekeeping. So during the presentations, everyone's going to have their cameras and their microphones muted. And please use the group chat feature to ask questions throughout the sessions. We're going to have questions and answers at the end, but please do put your questions in as you think about them. And just also to let you know, the session is going to be recorded, and a link will be available after the webinar with the slides. So we've got a really lovely agenda showcasing 3 bits of wonderful work that nurses have been doing to help our asthma patients. So first of all, we're going to have Tori Hadaway talking about group consultations in schools, followed by Laura King talking about a pilot in North East London, and then Alison Summerfield talking about MART. And at the end, as I said, questions and answers. So let's move on to our first presentation, which is going to be by Tori Hadaway. Welcome, Tori, and thank you for chatting with us and going through your work with us today.
Thank you, Pippa. So my name's Tori Hadaway, and I'm the Community and Children's Specialist Wheeze and Asthma Nurse in Tower Hamlets and the matron of the A to P service. I've looked after children with asthma for over 26 years. I have lots of experience and wanted to discuss how we can use our 4 Ask About Asthma asks in doing group consultations. Now, the group consultations that I did was while I was in the middle of working, so very busy in fitting in doing the group consultations, but I will explain how I did that. So group consultations are a way of bringing patients together with long-term conditions to help them better manage their own health and share in their learning and their experiences. Group consultation has benefit from the clinician as it's more efficient and less repetition, and better use of nursing time, targeting larger amounts of people in shorter time spans, improving patient waiting times. Obviously, had longer waiting times before doing group consultations. Group consultations for patient is efficient with better engagement, with reduction in missing appointments, enabling more time with clinicians, allowing patients to support and develop friendships, especially in schools. They get to know other children that also have asthma like them. So we first began by doing an engagement session, and this was basically to identify how we could improve asthma care in Tower Hamlets, and looking at what children, young people and families wanted. And what they wanted was to have more frequent appointments based in the community out of school hours, but they also wanted more interventions in school and more awareness in school, as they felt school needed to know how to manage their child asthma care. And we do know that a lot of families don't send their children to school when they have asthma attacks. So we felt that it was quite important to try and target schools and do a pilot to see if we could provide any support in schools around asthma. So we did some group consultations. So first of all, we engaged schools into the session, which was quite difficult. So we had an incentive that we would produce them with an asthma and allergy plan. We agreed time for the session based on what was best for the school, and we also asked for some parental involvement. We had discussions on what was expected from the school in advertising the session, providing translation support. We have quite a high Bengali population, and obviously I don't speak Bengali, so it was important that we were able to have support to translate for us. We also they were also required to send details of children that were on their registry if they had asthma plans. And this was one of the difficult things, that they didn't always send the information before the session and was gained after the session, which I found quite difficult and had to change some of the way we ran that afterwards. So we did 10 primary schools. It was very difficult to engage any secondary schools, so the pilot is just for primary schools. We had 287 children attend, with 93 parents and 23 staff attended. We did a pre-questionnaire that identified that most of the children were worried about having acute attacks, but also that they were worried. uh, they didn't know about poor symptom control, and they didn't know much about their exercise limitation, and that coughing at night time was poor symptoms. They were not using their PAPs or never seen one before, and they weren't escalating care to medical professionals. So we had quite a big target audience of children that didn't understand their asthma control and when they should seek medical help. So the group consultation was carried out using the pre and post questionnaire to identify their knowledge before the session and after the session. We asked the children and young people what they were worried about. So use like worry clouds for them to identify, and putting it in a worry box, what concerned them about their asthma. And then we had a discussion at the end just to make sure that we had covered what their worries were within the session. Most children were worried about having an asthma attack and actually stopping breathing, and also being admitted to hospital. We then carried out doing an interactive training session, and that was around asthma and allergy, what their medications for, how to use their spaces and their medication, looking at poor symptom control, looking at PAPs, how to use a PAP, and also to make sure that they knew when to seek medical review. Each child completed an asthma control test, and this was to identify which children had poor asthma symptoms. All children that had an ACT below 19 was referred into the specialist asthma clinic for further support, and looking if medication needed to be escalated. Everyone who um, came to the session received an information leaflet and a certificate of attendance. The certificate was just to make children feel good that they'd actually received something. And the information leaflet was basically to consolidate all of the information to be looked at a later date, but also to share with parents that were unable to attend the session. So the session identified that there was poor understanding on the role of the preventer inhaler, affecting compliance of regular use, which we know is an ongoing issue for most of our asthmatics. 60% did not have an asthma plan in schools, and not aware of what an asthma plan was, or that they actually had one at home. So this means that then they don't know when they should be seeking a medical review, or what they should be doing when they're acutely unwell with their asthma. 73% did not have the correct spacer, which obviously is affecting drug delivery. Found a lot of the children had the under five spacers, with the face masks. 38% had poor asthma control, unrecognised their symptoms. And out of those children that had poor ACTs, only 68% of them had had their annual review in the last year. So that also was an issue, that not everyone was receiving that annual review. So when we looked at feedback after the session, they did feel more confident in managing their asthma and wheeze, and actually would recommend the session to their peers. So when we looked at the 63% of the follow-up that had the poor ACTs in clinic, they had improved knowledge and compliance of their inhaled corticosteroids. So their ACTs had improved, but 37% still had poor ACTs and needed further management in treatment of changing their medication. So some of the barriers that was very difficult in getting schools involved. It was often felt that it was extra work, and they weren't happy about having to maybe put in the extra work for that. So selling it with that you would provide with an individual plan did actually help. We had quite a lot of schools that hadn't been receiving school nursing support. To have their individual plans in school, so they were quite keen to be involved. Um, some of the issues was the amount of parents. Some schools managed to get one or two parents to come, and other schools managed to get every single parent to come. So sometimes the sessions, if all of the parents come, was quite large and more difficult to manage. And some of the ways of think going forward is to actually have the sessions, parental sessions, separate to the children's sessions, just to make it more easier to manage and flow. Some of the children did not actually get a follow-up and come to specialist asthma clinic, and that was because school weren't happy to provide the registry, or I was chasing up because they had different names or they had a different date of birth, so it was really hard for me to find their information. So in future, when we're carrying out the more consultations, it's making sure that that's actually provided before they're actually given a date to enter into the groups on consultation. And obviously, with the larger sessions is a lot more chaotic than the smaller groups. So going forward, I would make sure that any big schools, that the sessions are actually having separate sessions, so it's easier to manage. So since doing the group consultations, we've managed to develop asthma-friendly guidelines with on e-learning resources, to make sure that we can get all of the teachers and support workers in schools aware of asthma, and expecting that they have 85% of their staff to be trained. We are continuing to work with Healthy Lives teams to get more schools asthma friendly. It's been very challenging. And we have also designed a standard asthma plan for every child. So at least they know what to do in an emergency if they're struggling with getting their individual plan from the GP or from clinicians. And often you find that the parents don't bring in the individual plan as well. So we've had a lot more communication with schools, with regular newsletters to share on updates about Ask About Asthma and pollution. Um, so that's been helping with relationships and sharing information with children and young people. And we've actually got managed to gain funding for two new nurses that have started with me now, so that we can go in and do group consultations in every school, so that we can increase awareness on asthma friendly schools, and supporting schools with improving awareness for children, young people. So hopefully that they improve their symptom control and reduce our hospital admissions. And we're also looking at doing some pilots in secondary schools, which obviously is a lot more difficult because they have larger numbers, and may require a whole school approach, or targeting year groups, and will require more intervention with going in more frequently to cover all of the children. And that's me finished.
Thank you, Tori. That was really, really interesting. What an amazing piece of work you've done. So I can see there are lots of questions coming into the chat. And as we mentioned, we're waiting till the very end and we will give you some of those questions then, if that's all right, Tori. But thank you.
Yep.
Really, really good.
Thank you.
And interesting. So I'm now going to move on to our second speaker, who is Laura King. Just waiting for the slides to move on. Hi, Laura, and welcome. And thank you for joining us today.
Just We're there. Can you see those, Pippa?
Yes, I can. Perfect. Thanks, Laura.
Okay, so hi everybody. My name's Laura King, and I'm, as you can see, I'm children's senior asthma practitioner for North East London and an asthma nurse by trade. So we're going to talk about the pilot in North East London. So let me just get started. So in terms of commissioning, myself and my colleague Jess are become a pair. We are the pilot team for North East London as part of the NHS England asthma practitioner pilot. So we are an asthma CNS and a respiratory physio. So we're really, really lucky in terms of our skill mix. What we've been doing is working sort of really closely with pretty much everyone actually in our boroughs across North East London. As you can see, we sort of are one of a pair that are spread across the whole of the country. So I think some of my colleagues are on here today, which is really fantastic. So what we've been doing is working essentially to try and find everybody across the whole of the patch that sees asthma and cares for children with asthma. And as we all know, asthma is pretty much everywhere. It's one of those conditions that sort of is found kind of in every healthcare setting, sort of every education setting, pretty much everywhere, especially in places like, housing and public health. So we've been really lucky in that we've got a really, really strong network to sort of start working with. So where are we? So we're in North East London. This is, I know, quite a colourful map, and it just shows kind of all of the people in our asthma network. You've just met Tori. So Tori is one of our fantastic asthma nurses that we work with really closely. We've got 7 boroughs, we've got 49 PCNs, we've got 283 practices, we've got 6 hospitals, a tertiary centre, within that 3 trusts. So we are we might be a small area geographically, but in terms of people and teams and population and certainly health services, we're really, really rich. So we've got a lot of people out there doing all the fantastic work like Tori's just described, but we've also got a lot of teams kind of out in the community and out in primary care that don't necessarily have the links yet to the asthma team. So something we've been doing, working really hard to do, is to try and get contact with sort of our teams outside of the hospitals and our teams outside of the asthma services to really feel involved and really feel that they are part of the work and that they kind of can feel confident to share the learning and to look after our children with asthma. In terms of where we are in a more general sense, as I've said, we're one of the most diverse kind of deprived and populated areas in the country, as many of us know. But, we're following a pandemic. We're in the middle of a cost of living crisis. As we all know, asthma is one of the conditions that affects the people with the least, kind of the most. And also, locally, we're one of the areas that in the last decade has had quite a lot of asthma deaths. So again, we're working really, really hard to try and negate some of the things that have contributed to those. So these are the aims for the NHSE pilot, and they are kind of based on the National Asthma Bundle. So if you wanted to learn a little bit more, that's where you want to go. So number 1 priority, establishing partnerships. And really, 7 months in to a 20-month project, Jess and I have found that this has been the most fundamental part to any of the work we've been doing. I'll talk about it a little bit more when I talk about learning, but finding the right humans and finding the right people, finding the right teams has been the most important part of the whole project. What we've found also is that we've found some people doing really incredible work that we didn't know about. So that's kind of the first aim for the whole pilot. The second being identifying areas where the outcomes are poorest. I'll talk about that again a little bit later, but we've been using various ways to try and sort of case find the children that are most high risk, but also find maybe patches that perhaps need a little more support, maybe need some more training, and perhaps would just benefit from feeling a little bit closer to the asthma network. And again, work to negate those, whether that's us going in and doing sort of joint work, and whether that's us making more links with the local teams. Number 4 is developing clear diagnostic pathways, and really heavily involved in this is the Community Diagnostics Centre work stream. So that's something that we're working really hard to do. It's early days in terms of our pilot, but I know some of my colleagues across the country have had some really fantastic outcomes with that in a really, really tricky financial situation across the country. So and that leads on quite nicely to leading on identifying children that are most at risk. So they might be children that have been in acutely, they might be children that have perhaps had a severe or a near fatal attack. And there's a whole work stream around sort of trying to find the more risky children in terms of the severity of their presentations, but it's also about finding the children that perhaps are more at risk of slipping under the radar. So the children who, you know, might have a subbutymal inhaler and no preventer, who might be merrily kind of wheezing away at home, but not coded as asthma, so not followed up. And Tori's just kind of shown us the value of finding some of these children. You know, when we're finding sort of 80% of children in schools that have got, you know, no plan or no follow-up or sort of no, it's really makes it really difficult for people to look after their asthma well. So these are just some of the projects we've got running at the moment in terms of all of the asthma bundle A. So something that we're really, really proud of is the asthma and allergy friendly schools work across North East London. My colleague Jess isn't here today, but she's been leading on that and she's done a really fantastic job. Looking at the pathway has also been fundamental. So again, as Tori's pointed out, we've got loads of children kind of in our borough who perhaps aren't getting the right care purely because we don't know about them. It's not because no one wants to do it. It's not for want of trying. It's just that they're really hard to find sometimes. And every single part of asthma kind of relies on us knowing the child's risk profile in terms of keeping them safe. One of the biggest sort of focuses we've had in North East London in general, so not just on myself, but just in general, is safe discharge. So we know that one of the most predictive factors of asthma death is having a severe attack in the past. So we've been working really, really hard across North East London as a huge, gigantic team effort to kind of get everything really consistent in terms of safe discharge. So that includes scrapping the subbutymal weaning, which I think we're probably going to talk about a bit more this week. And then really, really pushing just training. We know that if you don't understand asthma, it's really hard to offer really fantastic care. And certainly if our families and children don't understand asthma, their chances of managing that long-term condition are really, really low. So in terms of Ask About Asthma Week, we've been focusing sort of across the board. And again, this is a huge team effort. So Tori and all of the teams out there in the boroughs have been really focusing on training. We've been essentially just trying to train absolutely everyone that comes into contact with children with asthma and wheeze. So that's as part of our rollout of the safe use of subbutamol, which I'll talk about in a sec. Includes everyone you can imagine. You know, it's not just the hospital staff, it's GPs, it's school nurses, it's community nurses, it's you know, schools and children. And I know there's been a lot of work this week around sort of educating children in terms of breathing and how to look after their asthma. So this is a slide, I think it's a bit of a sneak preview for another day, but this is kind of a really great overview of what we've been doing in the last year. Obviously, we cannot take credit for all of these achievements because we, like I say, we have a really fantastic team. But what we found is that as in this sort of leadership role, we've been able to get this kind of unique oversight of sort of all of the projects happening in all of the boroughs. And you know, there's all 7 boroughs are kind of finite entities in themselves with their own teams and their own sort of pressures and their own aims, I suppose. And what we've been able to do is sort of have this fantastic oversight, but also get down to the granularity of what's happening in each borough. You know, what are our teams finding stressful? What's going on? Who's needing a little bit more support? You know, who's perhaps more focused on schools or more focused on primary care or perhaps more focused on, tier training or education. We've obviously been taking on leadership roles in a lot of these projects. And we've got our own work streams, but we've also found it really fantastic to be able to sort of come in and support our teams that are on the ground doing work like the schools work and the group consults. In some areas we've been taking on more of a coordinating role, and in some it's been a little bit like a sort of professional matchmaking service. You know, we've been finding people in one borough doing one thing, you know, that we didn't know about until we went out to see them, and then being able to match them up with someone in another borough across the network to see how we can sort of all work together. And our aim is really just to be consistent. So what we'd really like to see is it doesn't matter sort of where you go in now for your asthma care, you know, you'll get the same information, you'll get the same quality of service, and you'll get the same support. So that leads really nicely on to kind of one of our focuses, which is the safe discharge work stream. So this is essentially the scrapping of salbutamol weaning, and I know it's been quite kind of a political topic for a good few years. So we made collectively a panel decision to scrap the weaning regime in line with sort of the national and international picture. And what I'm really, really proud to say is that we've managed to implement that in all of our trusts. We've been really, really grateful to all of our teams. We've had fantastic engagement, and we're really proud to say that actually, as of sort of this month, all of our teams are ready to go. We are not going to be doing salbutamol weaning in any of our acute hospitals. So we've got quite a lot of children in our patch, as everywhere does, that could go to 1, 2, maybe even 3 hospitals. And it's really fantastic to be able to say that it doesn't matter where you attend, you will get the same information, you'll be discharged in the same way, and you will be just as safe. The next steps for that is the shared patient resource. So we'll talk about that on the next slide. We've got this booklet that we made kind of as part of this huge task and finish group, where we all kind of, sorry, chat's just popped up. We all joined forces to make kind of even down to the wording to figure out exactly what we want to say, what the onus want to put on. Sorry, excuse me. The the story we wanted to in terms of putting the kind of focus away from the blue inhaler and back onto the preventer and what's going to keep them safe. Yes, and I'm just sorry, my chat keeps popping up. I can of course share it. There's a QR code on the next slide. So this shared patient resource is one of the biggest wins for us, really. We're all really proud of it. It's been a huge group effort, like I say. It's in all the hospitals. It is out in primary care, but what we want is for everyone to be able to kind of know that they have access to it. When Jess and I have been out in primary care, what we found is that our colleagues out sort of in the GP practices are really, really pleased to be able to say that they're giving exactly the same information. And the kind of feedback we've had so far is that both the clinicians and the families feel a lot more confident knowing that they're getting the same information. So everyone feels kind of that the trust is kind of enhanced between teams and of course between families and clinicians. So I know I can see on the chat lots of people are asking about the booklet. If you can't scan the QR code, I can of course send it out. So these are the 2 things that we're using. We've got the Asthma and Lung UK plan, and we've got the BART's sort of NEL Asthma and How to Keep Your Child Well booklet. This includes kind of what to do on discharge, but it also includes all of the really fundamental information. You know, what is asthma? How do medications work? How do we stay well? And talking about the difference between a preventer and a reliever, you know, peak flow, air quality, stop smoking, all of the things all in one booklet, because that's what our families told us they wanted. They wanted it all together. And this means, of course, that it's not just a discharge resource. It's something that families can use kind of again and again. They can go back to it if they want a reminder. They can share it with schools. They can share it with, you know, other clinicians and other teams. But also, if they're not sure what to do at home, it aligns really beautifully with the asthma plan. So it's not just a discharge booklet. It is a booklet that you can use whenever you're worried about your child. I'm very mindful I'm tight on time. So moving on to asthma and allergy friendly schools. So this is Jess's baby. She is leading on it. Unfortunately, she couldn't be here today, but she's doing a really fantastic job. So as I've said, we've got all of these boroughs with their own sort of pressures and their own aims. And as you can see, every borough has got something happening. We've got the fantastic Tower Hamlets initiative, you know, alongside Tori's amazing work with the group consultations. We've got some boroughs where things are already well established. But we've also got boroughs where we're only just getting started. And one of the biggest achievements for Jess and the team has been the successful grant of the money for the Asthma Friendly Schools Coordinator. So for any of us that have been trying to do this work kind of on the side of another job, we know it's a full-time job. It's a role in itself. So we're really, really pleased to see sort of this kind of come to fruition. They'll be recruiting soon. So if you're interested, keep an eye out. And it's going to be a huge game changer for the work in those 3 enormous boroughs in our patch. So really, really exciting. And hopefully we'll have some more kind of for you next year as it kind of rolls out. The third kind of main focus for us really is primary care
Laura,
engagement.
You've got about 1 minute left. Sorry to interrupt.
Oh gosh, okay, sorry.
Gone quick, hasn't it?
Primary care engagement, so promotion of the tier training at every opportunity. Clinics which we've made sure are kind of joint. So our focus here is looking at kind of sustainable change. We're not coming in and saying, give us all your patients, we're going to take them away and see them. We're saying, how can we work together? How can we kind of embrace, the amazing learning culture in our patch and kind of foster our kind of collaborative working, and support the teams we've already got, these fantastic teams that we've got kind of out in our boroughs, who are really, really keen to learn. So our criteria are that the practice is taken up tier training, the clinics are joint, and we make sure that we have slots for case discussion so that we offer clinical supervision as well. This is just kind of the key resources, which is another massive thing that our primary care colleagues have said they've really felt more confident knowing they're using the same tools as us. So that's really, really fantastic. This is a little map of just the deprivation deciles across now and sort of where our clinics have been so far. It's not going to be any surprise to anyone that the children we've found so far that are kind of struggling the most are in the areas that are more deprived. And we've got a really interesting patch in terms of that. Oh, where's my slide not moving on? So just kind of, I promise I'm about to finish. We're looking at kind of empowering and upskilling the amazing teams we already have. As I've said, we're really focusing on this kind of sustainable supportive work, so that we can, our jobs are only for 20 months. If we're coming in and coming out, at least we're kind of leaving a legacy of change and learning. And yeah, so where are we? As I've said, we're 7 months in, we're just getting started. But in terms of the lessons learned, we've really, really, we've learned a hell of a lot about the value of the network. We've certainly learned a lot about using our amazing teams that are already there and not kind of reinventing the wheel. But also we've learned, I suppose, that change takes time. So we're just at the end of sort of the baselining. And as I've said, we've got these huge work streams going on, but yeah, we're just at the forefront of kind of making these large scale changes. So yeah, I'll stop there because I think there's lots of questions.
Thank you, Laura. That was absolutely amazing. And clearly a lot of very hard work's gone into that over the last few months, years. Yes, lots of questions have come into the group chat and lots of requests to share information, but we're going to move on first to Alison, who's going to talk to us about SMART project, and we can address some of those questions at the end, if that's right. Thanks, and welcome to Alison Summerfield, nurse consultant at Hillingdon Hospital, and is going to be spending some time talking about the MARC regime. Welcome, Alison.
Thank you, Fifa. And can you just check that you can see my slides?
Yep, can see
Wonderful.
your slides.
Okay, that's always the biggest challenge to start with. So I'm going to talk just for the next sort of 12 to 15 minutes about MART, which hopefully everybody will have some appreciation and familiarity with already. But this is obviously focuses very nicely with widening our view, which is the theme of the Ask About Asthma Week this week. If it's of any interest, we are already seeing lots of children presenting acutely at the hospital, so I suspect this is an opportune time. So, widening our view, thinking about MART, and just a reminder that asthma, as we will all know, is an inflammatory condition, and I think this really is a useful thing to think about, particularly with this type of treatment, is remembering and not forgetting that inflammation is key when you're talking and thinking about asthma. So inflammation, as we all know, needs effective treatment, and for many children and young people that we see, I'm sure you all have heard the stories from families, oh, we think it's gone, they've been completely well during the summer months, oh, they've been absolutely fine, no symptoms. And that appreciation that inflammation doesn't just disappear and go away, it remains dormant like a volcano waiting to explode, but there's the potential for that to happen and things, obviously, as we all know, to be triggered and get significantly worse in a very short space of time. So the prescribing data from April 2023 shows us quite clearly, when you're looking at the greener respiratory prescribing data pack data, that in children and young people who have asthma, 83% of SABAs prescribed go to patients using 3 or more inhalers per year. And children and young people with asthma who use 3 or more SABRI inhalers per year have twice the risk of a severe asthma exacerbation, and ultimately that's what we're all trying to prevent happening. 70% of the total carbon footprint of inhaler devices in this country alone is represented by SABRs. So that's looking at, you know, the greener prescribing, the carbon footprint, but also highlights to us the number of youngsters who are needing to use more than the advised amount of salbutamol per year. So I think when you're thinking, you know, when we start to think about MART, simple steps, joint decisions and agreed plans. And I think for all of us, particularly as nurses, we're in an ideal position to talk through and work out with our patients, not for our patients, what might be best for them. Many families, children and young people, struggle significantly with twice daily regimes of preventative treatment. And actually they want something that's simple, it's uncomplicated, it's easy to use, and realistically makes life a little bit more easier for them. It gives us an opportunity to optimize treatment. And as I've said, joint decisions are really important in terms of working with these families rather than us making the decisions about which medicines they'll be on, which inhaler devices, and the regime of treatment. Adherence, I think, as I've mentioned, is always an enormous struggle for families. And I think hand on heart, all of us would say that actually, I'm not sure any of us have got any patients who take their medication 100% of the time, but the MART regime of treatment gives us the opportunity for change and to improve the outcomes for these families. And reducing the carbon footprint obviously is part of this, but I don't really see it personally as being, you know, the whole reason of thinking about the switch. Many of you will be familiar with the GINA guidelines, and the use of MART actually is step 1 on the guidelines, whereas obviously the BTS guidelines are very different, and we work our way up and towards this. And I will share some information in relation to the studies that have happened in New Zealand, which are really encouraging with the use of this treatment. So in April of this year, the MHRA approved the use of a combination asthma inhaler, Symbicort, for people with mild asthma. It's evidence-based. It shows that children and young people with mild asthma can be prescribed a Symbicort turbohaler without needing to be prescribed a separate reliever and preventer inhaler first. And this links in very nicely to the GINA guidelines. It's a maintenance and reliever treatment, hence the name MART. And when you look at the New Zealand studies, they talk about it as an anti-inflammatory reliever therapy, otherwise known as AIR. Symbicort is a 2-in-1 treatment used for both prevention and relief of symptoms, and is currently licensed for those young people 12 years and above. Asthma maintenance and reliever therapy for Symbicort 100/6 turbohaler. This is one of the doses available. I've mentioned the fact that it's licensed for children 12 to 17 years. And the maintenance dose is 2 puffs daily in 1 to 2 divided doses. They can use an extra puff as required for relief of symptoms, and increase that if necessary up to 6 puffs as required, really as a maximum of 8 puffs per day. In an emergency situation, it can be used for a limited time, but it's very heavily recommended that medical assessment is undertaken at this point if a child or young person is needing that amount of their Symbicort. And similarly, for the 12 to 17-year age group, for both of these doses, there's the 200/6 turbohaler, and the maintenance dosing for this is 2 puffs daily in 1 to 2 divided doses, increased if necessary to 2 puffs twice daily. And again, similar recommendations in terms of the amount of extra puffs that can be used as required, maximum of 8 puffs per day, and we're encouraging young people to seek help. You know, if they're needing more than their maintenance doses, particularly going up to 8 puffs in 24 hours, they must seek a medical review appointment face to face that day. So why should we think about and why should we use MART? I've already mentioned that it can be used as a reliever treatment in isolation. It can be used as a preventer and an anti-inflammatory reliever. And, you know, thinking about the fact that we know that the risks of using a short-acting beta-2 agonist as a long-term treatment, it gradually increases the severity of asthma because of the over-reliance on SABAs during exacerbations. Inhaled steroids are good at turning off or reversing the asthma inflammatory process. And in New Zealand, in adolescents and adults, they've managed throughout their whole primary care system to not even consider SABA as a treatment at all. And they've switched to the AIR regime throughout the primary care setting. The results of which are that for people who have mild to moderate asthma, there's a 50% reduction in severe exacerbations. They've been able to demonstrate this by taking that step 1 on the GINA guidelines from day one of diagnosis. So not waiting until that young person or adult is hospitalised, stepping in at the very beginning with this AIR or MART therapy. Severe asthma, it's not actually something that is recommended, and the studies have been done on mild to moderate patients with asthma. If you switch them to AIR, it reduces the risk of a severe episode by approximately 1/3. So you can see how incredible actually the results are from the New Zealand study. And I just thought I would share with you a case study of a young girl that we've been looking after. You can see she's a 12-year-old girl, so licensed to have the MART therapy. She has asthma. I would say moderate asthma, allergic rhinitis. She's got multiple food allergies and atopic eczema. When we saw her on the first occasion, her ACT score was 19 out of 25. Her FEV1, 1.42, and had significant reversibility. You can see 32% reversibility after BDR. FeNO, 23, surprisingly. But she had frequent use of her SABA inhaler and had needed 4 courses of oral steroids in the previous 6 months, and was on Seretide 125/25, 2 puffs twice daily via spacer. Now, her adherence, I would suggest that when we first saw her, very good at telling us what we wanted to hear. Yes, I take it every morning, every evening. But following up at home with 2 or 3 home visits and building that relationship, actually then talking about the fact that actually she really struggled to remember to use it, rushing out to school in the morning. Often that morning dose got missed, you know, remembering to take it with a busy evening of getting homework done, etc., normal lifestyle things. And actually she was really fed up, had very low mood, and just, you know, really had enough with this heavy burden of atopic disease. So we switched her to MART, and actually she started the MART regime at home whilst we switched her in clinic and gave the prescription. It was felt that it was really important to actually go through things in quite a lot of detail at home and get that relationship built up. Symbicort 200/6, 2 puffs twice daily for a preventer and reliever treatment, and as I've mentioned, the home visit. And she's had a tertiary referral for her atopic eczema, and very importantly, a school visit, not actually just about the inhaler, but also to think about, you know, the burden of atopic disease, the things that she's finding difficult at school, the stress associated with all of this. At her clinic appointment 2 months later, I was really pleased to hear and find that she had had no further courses of oral steroids. Her FEV1 had improved significantly and she had no reversibility. Adherence was so much better, and she actually hadn't needed to use any reliever doses of MART, and her ACT score had improved significantly. And overall, her asthma control was so much better, and she was much happier in herself. So I think, MART is now offering us an exciting opportunity to optimise children, particularly in the adolescent age groups. I think we need to think very carefully about inhaler technique. It's not the same as using it through an MDI and spacer. It's very different, and we need to consider that in terms of asthma management within school. It's very different. We have a very proactive Asthma Friendly Schools initiative in place, but it's different. We're putting a red and white inhaler in school rather than a blue inhaler and spacer. So training needs to be thought about, and the individualised plan needs to be shared. There's a potential to reduce the significant number of SABA inhalers being used per patient, alongside supporting the minimisation for the carbon footprint. And we have the potential to reduce hospitalisations and exacerbations of asthma in those children and young people that this type of treatment is suitable for. I've talked about the New Zealand data, which demonstrates significant reductions in asthma exacerbations and hospitalisations for young people who are over the age of 12 with both mild and more severe asthma. And I would encourage anyone who's not had the opportunity to listen to the podcast that Mark Levy leads with Professor Richard Beasley. It's really enlightening. And there is a study which will begin in January 2024. That's my understanding, at the Brompton Hospital for children and young people with asthma who are younger than 12 years of age. So I think this is, an opportunity for us to watch and see, and will potentially transform quite a lot of our practice in managing children and young people's asthma. Now I'm going to stop sharing my slides now, because I'm going to hand back to Pippa just for clarity, because I'm not sure everyone will be very familiar with using spacers and MDIs for children and young people. But I know yesterday I attended a presentation with one of our pharmacists from the Brompton Hospital, who shared a wonderful story about a patient discharged from hospital with the correct prescription, but actually then the mum was trying to put the turbohaler through the spacer. So Pippa is going to very kindly demonstrate the technique, and I'm going to talk it through just as we go. So this is the red and white Symbicort turbohaler, as I say, available in 2 doses, untwisting and lifting off the lid. And then really important, you hold that turbohaler upright, pointing to the sky, twist it round and back as far as it will go, then holding the turbohaler away from the mouth, breathing out, and then putting in between the teeth and lips a big, deep suck in, and then hold for 10 seconds. So it's a very different technique, and this is something that we obviously need to share with our colleagues in primary care, in schools, because ultimately, as you will all be very aware, the inhaler technique with children and young people is so important in getting that medication down into those small airways, alongside encouraging them to take it regularly. So I'm going to finish there, hand back to Pippa.
Thank you so much, Alison. That was lovely. Really interesting talk. Now, I'm mindful we've got about 11 minutes left and lots and lots of questions. The first question I'm going to ask Tori to answer, please. And the question is, what was the children and parents to healthcare professional ratio in your sessions?
So obviously when I did the session, it was myself, and I had asked school to provide 2 asthma champions or a first aider. So they were in with the session, and sometimes there might have been a few other staff. If they had like TAs with individual children, then they would come as well. So the parent ratio depended on what school. Some schools I might have had 15 parents, another I might have had one. Obviously, the children ratio was a lot higher, so it could range from anything from having maybe 15 to 30 pupils in each session.
Thank you. And then again for you, Tori, lots of questions about what you've been doing. Did you have any challenges gaining parental consent to allow the group consultations to take place?
Because you're doing it in school, the school have consent because the child's actually in school. So if I was doing group consultations in clinic myself, then I would have to gain parental consent with a letter to say that they were consenting, that they were happy to have it as a group. But in schools, they didn't need to do that.
Oh, that's really useful to know. And what age range did you have in your sessions? Because you talked about primary schools. Did you sort of
Yeah.
clump together, year one right up to year
Because
6?
when I went in originally, I went quite blindly. I didn't know how many children were going to be there because they weren't giving me the list of who they had. So it would range from anyone from 6 to 9. So going forward, what I would do is I would separate the youngers and give them a slightly different session to what I would with the older children.
Thank you. And then I think this is the last. Oh no, I think you've mentioned this in the chat about the struggling with secondary school capacity. I think you've answered that.
Yeah, I think that's my new challenges with secondary schools. And I think I was trying to think that maybe tackling the year 7s when they first start, because I think that's a good transition period of where they're going into more independence, to try and target those. But really, I would love to do a whole school approach, because I don't think it's just the children with asthma that need to be aware, it's their peers as well as allergy, and to increase awareness with everybody. And doing it in assemblies, I think that is a good way forward. But it's always difficult with schools because you want to offer them a service that they want and is going to meet their needs. So I have been quite like, how do you want me to do this, and trying to get their involvement in that. But I do know that there's a lot of asthma friendly schools where they have a nurse that specifically does that, and they will go in and do secondary assemblies and do it as a whole school approach.
Brilliant. Thanks, Tori. So moving on to you, Laura. How have you managed to get buy-in to add allergy into your asthma-friendly schools programme?
So I think we've probably just been a little bit cheeky, and we've just gone from the beginning. We've just called it asthma and allergy friendly schools because we just appreciate that, ATP doesn't come on its own. We've basically just gone, like I say, we just called it that from the start. And kind of just almost presented it as a package deal. And I know that sounds really, really simple, but that's essentially what we've done. And I think, I don't know about, maybe Tori has found differently, but when I've been in other jobs and we've been working with schools around children with asthma and allergies, the schools seem a little bit more anxious about allergies than they do with asthma. So it's almost done us a little bit of a favour because they're more worried about that. So bundling them together has been really handy. But essentially, yeah, we're just kind of brazenly just gone for it and put them together.
I think it was the fact that you're going in to do one, so why not just do the other and add to the other? And it was also looking at, we're expecting them to have their own medication emergency kit. And obviously the EpiPens is sort of a normal part of that. So rather than going in and doing another session another time, it was easier just to bring it all together.
Yeah, and I think they like that. The feedback's been kind of, we like to put them together because it's largely the same kids, isn't it? So yeah.
Lovely, thank you. So I've got a question for you, Alison. Do you check inspiratory flow to check that the turbohaler's appropriate?
So I think that comes with experience. We as a team generally don't use the inspiratory flow gauge now, but I think that's because we've been using the turbohalers quite frequently. But I think it absolutely is really important that you are sure that the child has got the inspiratory flow and effort to be able to use the device. Some children or young people of 13 will not be able to manage it for one reason or another, and their technique needs to be efficient and consistent. Otherwise, it's not going to work. So it's really, really important.
I would actually recommend, I don't know if lots of people in this group use the whistle halers. We try and check our children's respiratory flow using those, which I think is really good. A question for all of you now. What do we know about the reasons for increase in prevalence over the years? And is there any work taking place to reduce the increase? Does anybody want to step in?
I mean, I feel that maybe a lot of the increase is because of pollution, and obviously we have increasing amounts of pollution in London, and I think that's affecting a lot more of our children, and also poor housing conditions. We have a lot of children living in damp and mould, so when they're exposed to that at a young age, a lot of the preschool wheezer types are all exposed to poor housing and smoking. I think all of those things are triggering and causing more of an issue. And I think in lots of areas, we are all trying to do housing letters. We are trying to do lots of smoking cessation and also trying to improve mould. I know there's been an initiative amongst most of the councils to improve some of the housing so that maybe some of that may help following the death of that child that's been living in mould.
Yeah. Thank you, Tori. Yeah, go for it.
No, I
Alison.
was just going to say, I think people are very much more aware now of symptoms associated with asthma, and also the availability in certain settings of diagnostics. So certainly I think that's quite important. I don't think that we're there yet in terms of availability for children and young people of the likes of spirometry and pheno, because we just don't have the number of staff trained to be able to roll it out across the board. But I think, you know, people are just much more aware in terms of symptoms. And as you mentioned, Tori, housing, socioeconomic factors do play a big part in many of the children and families that we see.
Thanks,
Yeah,
Alison.
I'm just going to agree with Alison. I think we're getting better. I know we're not there yet, like you said, we're getting better at diagnosing. And I think the fact, I mean, one of the work streams I'm working on is looking at the diagnosis, the diagnostic testing. And if you took as a good kind of measure the amount of tests that are being requested versus the amount we actually have, I think people are really aware. Like you say, they're more aware of the symptoms, they're more aware of the nuances and the more kind of subtle symptoms. But yeah, it's we've still got a long way to go, haven't we, in terms of actually giving kind of quality and early diagnosis.
Thank you. Alison, another question is just going back to MART again. Is there anybody that MART wouldn't be suitable for? Anyone over the age of 12 who you wouldn't consider using MART for?
I think most of that's going to boil down to the fact, can they actually use the device? So there will be some young people who've got additional needs who will never be able to create the inspiratory effort to be able to use it. I think one other group of patients that I'm always a little bit hesitant about, particularly in starting, we normally give them their first dose, is those children and young people who have particular allergies. So, you know, certainly those who've got milk allergy, for example, and the lactose component. So we normally start that off, their first doses in hospital. But I think it should be considered for all, and actually, with it being part of the GINA guidelines and the BTS guidelines are obviously being revised, I hope that there will be a combining of those guidelines that give us the opportunity to consider using it. And I think, if I'm really honest, I think the group of youngsters that are going to benefit the most are the adolescents, who find it very difficult for one reason or another to remember to take their preventer inhaler regularly. And if you can get reliever and preventer, a 2-in-1 inhaler in at the same time, it's a no-brainer really, because they're going to take it when they need it.
Yeah, I mean, I think I would definitely agree with you, Alison. We see some amazing results when we switch people to MART. Goodness, there's so many questions and comments coming up in the chat, and I'm just really mindful that we are about to end. Lots of questions wanting resources and so forth. I know that all the presentations are going to be shared, and I know that if there's anything like housing letters, smart MART plans, etc., individual, you can email individually if that's all right. I know that everything's going to be shared at the end of the session as well. So I am mindful it's 2 o'clock. Just a massive thank you to Alison, Laura and Tori for taking time out of your busy week to come and talk to us about what you've been up to over the last year, few months. And just a reminder to fill out the evaluation form, please, to everybody who's joined. And thank you as well to, I think at one point we had about 115 nurses who were on the call listening. So that's just been amazing. Thank you.